disorders. One of the more interesting ones is Devic's disease, or Neuromyelitis Optica, and Dr. Wingerchuk is going to be talking about that. I also want to add quickly and very personally that I am very grateful to Dr. Wingerchuk. If there is a patient with Devic's disease in the United States, this is the gentleman that I refer them to, and he provides excellent care to people who have this very complicated disorder. So, and Dr. Wingerchuk.
Well, good afternoon. Thank you very much, Sanford, for that kind introduction. You've got a long afternoon ahead of you. I'll try to get us back on track. Hopefully you're still awake after that lunch. I'm going to be speaking about neuromyelitis optica, which is often referred to as Devic syndrome or Devic's disease, and has long been thought to be a variant of multiple sclerosis, although, as you'll see from some of the material that I present today, there's some evidence that's accumulating to suggest that it is quite distinct. It should be treated differently, and perhaps it's even a different disease. And what I'm going to do at the beginning is just present for you history from a young man, a patient that I saw within the last few months that I think gives you the flavor, for those of you who aren't familiar with the disorder, of what it is often like in its relapsing form, where people have recurrent events. This is a young man, an African-American gentleman who is now 21 years old. When he was 7, he developed transverse myelitis, and his spinal fluid showed an increased number of cells, and also they thought that he might have Lyme disease at the time because of a positive Lyme titer, and they treated him with steroids and with penicillin, and he made a partial recovery. Over the next 8 years, he had 5 more attacks of myelitis, and during one of those attacks, his spinal fluid that I had access to showed a large number of cells, 92. That's unusual for what we usually see in multiple sclerosis. And in addition to that, it had a substantial proportion of what are called polymorphonuclear cells, and we also don't usually see that in typical multiple sclerosis. And he didn't have oligoclonal bands in his spinal fluid. Most people with MS do. Now, each of those attacks was generally treated with steroids, and he got partially better, but he was accumulating disability, and by the time he was 15, he really wasn't walking anymore. When he was 15, somebody put him on prednisone, and he stayed on rather low doses of prednisone, actually, for the next 3 years and had no attacks. Then he went off of prednisone, and in the next 3 years, almost up until the time I saw him, he had, on average, 2 more spinal cord attacks each year. People weren't sure what he had. Some thought he had MS, some thought that he had a vasculitis of the nervous system, and he was treated with Cytoxan and methotrexate. They didn't seem to work. Then after about 15 years of disease, he finally presented with optic neuritis. And this is after having experienced more than a dozen attacks of myelitis. And he had bilateral optic neuritis that was treated at his home institution with steroids and then plasma exchange, and you'll hear more about plasma exchange soon. And then he was treated with Cytoxan. Unfortunately, the morning that I saw him, he presented to me with his next event of bilateral optic neuritis, and he was completely blind in one eye and quite impaired in the other eye. And on his examination, he only had useful function of one arm and had severely impaired vision. His laboratory studies show what at least some patients with this disorder have, is that some antibodies, autoimmune antibodies, not specific ones necessarily, but nevertheless in a panel that we do, turn out positive. And this tends to occur more often than in people with multiple sclerosis. He had lots of imaging studies in the past of his spinal cord and of his brain, and this is an image of his brain which shows a few white spots, but you can see that by and large most of the brain is spared, and for somebody who's had neurological disease for as long as he has, if this were multiple sclerosis, one would expect to see a lot more. Now this actually isn't his MRI, because I don't have any of his old MRIs that show what it looked like when he had an acute episode of myelitis. But this is, I think, a good example of what a lesion in neuromyelitis optica typically looks like. This gray structure that runs vertically here is the spinal cord, and you can see beginning at this level and extending up about 4 of these bony segments in the spine is this long white lesion that expands the cord. That's all inflammation, demyelination, damage to the spinal cord, and that's a much longer lesion than we usually see in multiple sclerosis. Now, unfortunately, he had so many attacks that his spinal cord had been damaged to a degree that it started to shrink. And you can see in this section, you can recognize here the brain and here the spinal cord, that it's very thin in this area, or atrophic. And that shows the same thing. In cross-section, here's the upper part of his spinal cord, which this little gray oval here, and as we move down his spine, it actually almost disappears. This is just this little ribbon right here and here, and then at the bottom, near the bottom of his spinal cord, it reemerges again. So unfortunately, he's had so many devastating attacks of myelitis that over the years that his spinal cord has lost most of the fibers and has shrunken. So I felt after seeing him that clinically, just simply based on what had happened to him over the decade and a half, that he had what we call relapsing neuromyelitis optica. And we treated him with steroids, and then we actually treated him with plasma exchange because his vision didn't get better. And he made at least a partial recovery in the next month of follow-up. He lives out of state from where I am, so I haven't been able to actually see him back recently. So I think that case encapsulates many of the features of what are rather typical about of what we call Devics or neuromyelitis optica. And historically, and it's still written sometimes in textbooks, that this is a disorder where people get an attack of myelitis that's associated with bilateral optic neuritis, that it all happens pretty much at once and then it never comes back, a so-called monophasic or single-phase disease. And my colleagues at Mayo Clinic in Rochester, including Dr. Weinschenker, whom you'll hear from later this afternoon, and I put together our experience at Mayo Clinic that actually extends far back beyond when any of us were there, back to the early part or the mid part of the 20th century. And we were able to gather 71 patients and look at their long-term course. And we found that there are many people that seem to have what we recognized as Devic syndrome, a course that was quite different than typical multiple sclerosis, yet didn't fit very well with that historical definition, in that many of the patients, although they had a course that was otherwise identical, had only optic neuritis on one side. Most of the patients, in fact, didn't have a bunch of attacks altogether and then stop. They, in fact, had attacks that would occur a few weeks or months apart, and then they would go into remission for a while and then have another cluster of attacks, and this may go on for years, not unlike what you see in multiple sclerosis. We also found, at least in this group of patients or cohort of patients that we studied, that the natural history seemed to be very poor. People did much worse than we usually see in multiple sclerosis. In particular, one concerning feature was that in attacks of cervical myelitis, transverse myelitis in the upper part of the spinal cord, that sometimes would ascend up into the brain stem where the neurological center for breathing is, and people would develop respiratory failure. And especially in years past where medical support was not as advanced as it was now, sometimes people would die. So putting together all of the information that we had gathered from the literature and our own experience, we proposed some diagnostic criteria, and this is all in your syllabus. We don't have to spend too much time on it, but what we've tried to do is provide a platform to help doctors and researchers recognize this diagnosis as separate from multiple sclerosis, or potentially separate, and as a starting point to be able to advance our research. And some of the aspects that I've discussed in the case presentation are encapsulated here. So people, to fulfill the diagnosis, needed to have optic neuritis and myelitis, but no evidence of disease elsewhere in the brain or in the nervous system. Usually people have a negative brain MRI, meaning they don't have spots that look like multiple sclerosis at the onset of the disease. They have a spinal cord MRI that looks like I showed you, with a very long lesion that extends over multiple segments of the spinal cord. And their spinal fluid tends to show a lot more inflammation and a specific pattern of inflammation, different than multiple sclerosis. And then we built into this a little bit the severity of what we'd seen in our case series, the fact that a more severe optic neuritis, a more severe myelitis, or bilateral optic neuritis, all of those things were more suggestive, we thought, of Devic's than multiple sclerosis. This is just a visual summary of the patients that we had studied, and you can see that along the axis here we have follow-up, some patients more than 2 decades, but you can see that each of these little circles or triangles signifies an attack, and many people had clusters of attacks that would occur many, many years after the onset of the disease. So this actually looks not unlike what you might see in multiple sclerosis, but certainly doesn't fit the historical definition of Devic's. Many people, it seems, have relapsing disease. There are still some patients that do fit that more historical definition, where they will have bilateral optic neuritis and an attack of myelitis. It all occurs within a few days or a week, and then, at least as long as we follow them, they don't have any more attacks. The people that have relapsing disease, though, seem to be much more common. Unfortunately, because they have relapses, they continue to accrue disability. So although they might get some better from attacks, the fact that they keep having them means that they lose function over time. And that actually happens much quicker in Devic's than it does in multiple sclerosis. We found that many people within 5 years in that group of Devic's patients either were no longer able to walk or were what we generally call legally blind in at least one eye. And that's, of course, much different than what we see in multiple sclerosis. This is a table that just demonstrated the fact that some of these patients actually died from respiratory failure. Sometimes when I see patients, they tell me that they've looked at our papers in the literature and they've become frightened, and this certainly is frightening information, though, as you'll see, and I'll discuss a little bit more, the more we recognize this disorder, which certainly has been under-recognized over the past few decades, the more we recognize that there's a much wider spectrum, I think, than we initially realized. And there certainly are patients that have milder disease but still fit into the context of Devic's. I mentioned the brain MRI results. Sometimes after people have had Devic's for a number of years, they do develop some spots on their MRI. Many times they're non-specific spots, meaning that they don't necessarily meet criteria for any diagnosis, but sometimes they actually do look like what we see in MS, but that's uncommon. The spinal cord I've already discussed. This is that same lesion that I showed you before that extends over multiple segments of the spinal cord, here over about a total of 4 segments. This is the abnormality here, this sort of popcorn-looking area, which is the lesion that's expanded the spinal cord. It's very swollen in that area. Again, an unusual appearance for multiple sclerosis. And then this is after the person's been given an infusion of gadolinium during the MRI, which shows that this area lights up, it's inflamed. The spinal fluid I mentioned shows some characteristic features in some patients with Devic's that can help distinguish it from MS, in particular more inflammation, the presence of these cells called neutrophils. It's still a minority of people, but when we see that, it supports a diagnosis of NMO. So this sort of summarizes the advances in some of our thinking about the diagnosis over the past almost decade, moving from the older or historical definition of Devic's to one that is somewhat more broad, including people with both unilateral and bilateral optic neuritis, better defining the type of myelitis that these people have, because not all people with transverse myelitis have this kind of pattern. In fact, many don't. The fact that many people have relapsing disease and the MRI scan can be normal. So what we and other groups who are interested in this sort of tried to do is advance the understanding and diagnostic criteria to make people more aware of recognizing the disorder and distinguishing it from multiple sclerosis. Further evidence to support that this is a different disease or different entity than MS comes from pathological studies. And throughout the 20th century, there were a number of studies, mainly autopsy studies, where people had shown that in the spinal cord, the lesions that caused the myelitis were very extensive, very severe, and really caused essentially death or necrosis of the spinal cord, not just inflammation. More recent studies have confirmed that that pattern of inflammation is different than from what we usually see in MS. It's got these cells, neutrophils, and not only that, something called eosinophils, which is a very, very unusual finding and maybe rather specific for this disorder. Another interesting finding that goes back to the 1970s is something called vascular hyalinization. The blood vessels around the spinal cord become somewhat thickened. And we don't know what that means, if that means that somehow the blood vessels or the vasculature of the body is actually involved in what's going on in causing the disease in the first place, or that's just a reaction to all of the damage that occurs in the spinal cord, but it is, again, distinct. More recently, studies led by Claudia Lucanetti at Mayo Clinic and others in Europe have shown that the pathology of Devics and the immunology, again, is quite distinct. And in particular, we think that Devics is what's called a humorally mediated disorder, meaning antibodies are of primary importance. And that's shown pathologically, and it fits together with the concept of this being an antibody or B-cell mediated disorder. And all of these lines of evidence support that, including the fact that many people with Devics will have other kinds of autoimmune disease, like thyroid disease, for example. There's an animal model of multiple sclerosis called EAE, and one particular form of that actually mimics Devics-type pathology very well. I mentioned the pattern of inflammation in the spinal cord. As you'll hear from Dr. Weinschenker, many people who have Devics disease who have a very severe attack of myelitis that doesn't get better with steroids will respond well to plasma exchange, and plasma exchange is a procedure where the blood is essentially filtered and antibodies are taken away from it. Most exciting, we think, recently is the discovery by another one of our Mayo Clinic colleagues, Dr. Vanda Lennon, is potentially a rather specific diagnostic test for NMO or Devics. This is an antibody marker that can be tested in blood or serum that seems quite powerful in discriminating this disorder from multiple sclerosis. And Dr. Lennon has a very large neuroimmunology laboratory in Rochester, and she, working initially with Dr. Weinschenker, recognized in a very small number of samples that this pattern, this marker came up, and she didn't know what it was, and they looked back at the kinds of disorders that the people had whose blood had been sent in and had this antibody turn up positive, and it turned out that many of them had either Devics or an attack of very extensive myelitis within the spinal cord, like I showed the MRI, or recurrent episodes of optic neuritis. In other words, about 2/3 of these patients at least had a pattern that was either Devics or perhaps evolving Devics or incomplete Devics. And that was pretty interesting because we think Devics is if not rare, certainly uncommon. And yet to find that it made up a large proportion of this cohort of patients that had this antibody positive was quite intriguing. So a number of us assisted in a study where we started to send blood to Dr. Lennon to look for this marker in people that had what we thought was Devics, other people that looked like they had they might have Devics because they presented with a significant spinal cord problem or optic neuritis, but ultimately they turned out to have multiple sclerosis. And then another group of patients who had recurrent episodes of myelitis or recurrent episodes of optic neuritis that hadn't yet turned into Devics. And what we found was that, and this is actually some of the initial data, about 2/3 of the patients with Devics had this antibody marker. A little less than half of the patients that we think were sort of incomplete Devics, if you will, had the marker, and only 9% of the patients with MS. And these, even those MS patients, are ones where the doctor looking after the person initially thought this could be Devics. So it wasn't all MS cases. If someone presented with double vision, we didn't send the antibody. It was if somebody presented with a spinal cord or optic nerve problem. Since the development of these data, we've got a lot more experience, and Dr. Lennon has optimized the assay some more, and we now think that it's at least 75% sensitive in being able to pick out who has Devic's disease, and it's almost never seen in typical multiple sclerosis. That's just summarized in those boxes. So this slide just summarizes and extends some of the features that I showed before, and I think is a handy way to think about how one can separate the presentation of Devic's disease from a presentation of multiple sclerosis on the basis of clinical features such as the type and severity of attacks, the MRI scan, the spinal fluid, and then we hope and we think the use of this new autoantibody marker. And we always like to diagnose things earlier in order to be able to initiate treatments that might have a beneficial effect. And as many of you probably know, in multiple sclerosis, that's a very widely held viewpoint. Diagnose early, treat early, because if you treat early, you might be able to save significant function. We think that's even more important in Devic's disease, and one of the main reasons for that is that almost all of the disability or handicap that occurs because of attacks in Devic's. In other words, people don't develop progressive disease in Devic's where things gradually and slowly worsen over time. That's very uncommon. That's very common in MS, but very uncommon in Devic's. What happens to people with Devic's is that they keep having attacks. So we think that if we can actually prevent attacks, we probably stand to keep people with this disorder in much better shape. We don't have controlled studies in Devic's. That is, we don't have studies where we can look at where people with the disease have been randomized to get one treatment or another, and we've tested which treatment is better. We simply have the experience of people who have seen a lot of people with this disorder and tried treatments and their opinion about what helps. And in general, we think that it's likely that the typical treatments for multiple sclerosis, interferons, et cetera, don't seem to have an impact on Devic's. They don't seem to stop attacks. They don't seem to impact disability. What we think needs to be done is actually immune suppress people, and I'll discuss that more in a bit. Dr. Weinshanker is going to talk more about plasma exchange, but for treatment of acute attacks, we treat acute attacks of neuromyelitis optica very similar to how we treat acute attacks of all other types of central nervous system demyelinating diseases, including MS. We try steroids. If steroids don't work, Dr. Weinshanker's study clearly shows that plasma exchange is the next route to try. The next important thing is attack prevention. I mentioned that the standard MS therapies may not be effective. We usually go immediately, once the diagnosis is made, to trying to suppress the immune system to some degree. A standard treatment generally over the past few years has been a combination of prednisone taken by mouth plus azathioprine, which is also known as Imuran. And prednisone works almost immediately. Imuran takes a few months to kick in. I try at least to keep people on a combination of this initially until we have evidence that the Imuran is working, and then eventually taper the prednisone away, hopefully to be able to discontinue it, although some people are not able to achieve that. There's a newer drug called Cellcept, which is a little perhaps better tolerated, a lot more expensive, which can do the same job. Because of the severity of this disorder and its relatively newly recognized status, it's the kind of thing when you look through the medical literature, people have thrown a lot of things at it to see if it might help. And so mitoxantrone, which is an immune suppressant drug used in multiple sclerosis, has been used, and one group in New York has some experience with this and feels that it's helpful. Other people have used Cytoxan or cyclophosphamide, which is a fairly powerful immune suppressant drug. The last 4 treatments that I've listed there are what might be considered more B-cell specific or antibody specific therapies. And based on what we recognize about the pathology and the clinical aspects of this disorder, perhaps it makes sense to study them in more detail. So intravenous immune globulin, which is definitely available. Plasma exchange, perhaps repeated courses of plasma exchange might be useful. We don't know that. There's at least one report and some logic behind the use of a drug called chlorambucil, which has immune suppressant effects. And very interestingly, and reported by the group at University of California at San Francisco this year, is the use of a new drug called rituximab, or Rituxan. This drug is used primarily in disorders like rheumatoid arthritis, which is also an antibody-mediated disease, we think. This is a very specific drug. It's an antibody which is directed against the B cell, the cells that make antibodies. It kills them, and it knocks them out for an extended period of time. And there's some preliminary evidence to show that, that at least people tolerate it well, and perhaps in the short term it might help prevent attacks. Our group at Mayo Clinic has started using this for some people. I just wanted to follow up at the end about the gentleman that I presented at the beginning of this presentation. I started when he was 7 years old, I believe, but actually I left out the part that happened to him when he was 6 at the beginning. He actually presented, his very first event was neck pain, neck stiffness, and fever, and then he developed severe right-sided weakness that gradually worsened over 4 days. He was initially diagnosed with a stroke, but really that's not the history of a stroke. He didn't have a spinal tap at the time. He did get partially better from that attack, but this is what the cause of that abnormality was. That's a lesion in the left side of his brain. And essentially this is just a big cavity now. And what I think that was is actually the very first event of what he had with Devic syndrome, not a stroke. And what this tells us is that the spectrum of Devic's disease is wider than even our definition at present allows for. There are people that have some brain involvement. There are people who have somewhat atypical MRIs, and there's more that we have to learn about the disorder. So after treating him with plasma exchange for his vision, because he'd been on so many treatments, including immunosuppressive treatments, and was such as Cytoxan most recently, and continuing to have attacks, I treated him with this drug rituximab, and he seems to be doing well so far. We're still working on trying to fine-tune how we diagnose this disorder and discriminate it from MS, and so we've changed some of our criteria a little bit, not formally, but at least operationally, to try to include these groups of patients who have recurrent myelitis only or recurrent optic neuritis. One thing that we think is very important is the MRI scan of the spinal cord. For people with myelitis, it seems almost universal that people that have Devic's disease have cord lesions that are very long and extensive on the MRI. And we're still working to try to validate our new antibody study. And so there's a group in Rochester and myself who are looking at all of the patients that we see at Mayo Clinic, blood from patients that are seen elsewhere, and the clinical course and MRI and spinal fluid results in order to see how good this test actually is. People in the laboratory working on what it actually means. So it's quite an exciting finding, and certainly is the first finding of this type in all forms of brain demyelinating diseases. So I'll conclude by saying that the spectrum of this disorder is still being recognized, and certainly wider than we initially thought. We know because of clinical experience and because of some of the results from our antibody study that this spectrum of disorders also includes people who have recurrent myelitis only or recurrent optic neuritis only. And I certainly can think of several people that I've looked after who have had many attacks, just like this gentleman I presented to you today, many attacks of spinal cord disease, and years later converted into neuromyelitis optica. We think that this antibody is very specific for NMO and that it will be useful in helping make a diagnosis and allow us to treat people earlier and hopefully better. And the evidence is building that this is an antibody-mediated disease, which helps us a lot. It helps us think about how to attack it much more specifically. I've talked for almost exactly 30 minutes, so I'm going to stop there. We don't have a lot of time for questions and things, but I'd be more than happy to speak with any of you who might have questions later this afternoon or this evening. Thank you very much.